Welcome to Guideline Central. My name is Dr. Tabitha Michaud, and today we'll be discussing the ATS, or American Thoracic Society's 2020 guidelines titled The Pharmacological Management of Chronic Obstructive Pulmonary Disease, published April 2020 in the American Journal of Respiratory and Critical Care Medicine. The target audience for this guideline includes specialists in respiratory medicine, but given how common COPD is, these recommendations are also for primary care physicians and other healthcare professionals taking care of patients with COPD. And the purpose of this guideline is to answer specific clinically important questions regarding the pharmacological management of COPD, with aims to improve the quality of life and control symptoms while reducing the frequency of exacerbations for patients with COPD. Now for this guideline, a comprehensive evidence synthesis was done of all relevant studies in a literature search from 1990 to January of 2019. And for these recommendations, the expert panel has used the grade method to evaluate and assign recommendation gradings. And that means for each of these recommendations, there will be both a strength of recommendation grading of either strong or conditional or weak, as well as a certainty of evidence grading of high, moderate, low, or very low. And with that, the ATS answers 6 clinically relevant questions on the pharmacological management of COPD. So let's get into the guidelines. Now, before we get into the recommendations in our quick reference format, we want to go over a couple of abbreviations and definitions, starting with the ATS's definition of COPD, which is based on the Global Initiative of Chronic Obstructive Lung Disease 2019 report, which defines COPD as a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. And for the abbreviations, our first is ICS for inhaled corticosteroids, LABA for long-acting beta-2 agonists, and LAMA, or long-acting muscarinic antagonists. And with that, our first recommendation from the ATS is a strong recommendation with a moderate certainty of evidence. And here, the ATS recommends that for patients with COPD and exercise intolerance or dyspnea, they recommend for the use of a long-acting beta agonist in combination with a long-acting muscarinic antagonist as opposed to monotherapy. Our second recommendation from the ATS is a conditional recommendation with a moderate certainty of evidence, and here the ATS suggests that in patients with COPD who complain of dyspnea or exercise intolerance despite dual therapy with a long-acting beta agonist and muscarinic antagonist, the ATA suggests for the use of triple therapy with inhaled corticosteroids added over dual therapy with a long-acting beta agonist and muscarinic antagonist in those patients with a history of 1 or more exacerbations in the past year requiring antibiotics or oral steroids or hospitalization. For our third recommendation, this is a conditional recommendation with a moderate certainty of evidence. And here, the ATS suggests that for patients with COPD on triple therapy, ICS can be withdrawn for patients who had not had any exacerbations within the past year. Our fourth recommendation from the ATS is a conditional recommendation with a moderate certainty of evidence, and here the ATS does not make a recommendation for or against ICS as an additive therapy to long-acting bronchodilators in patients with COPD and blood eosinophilia, except for those patients with a history of 1 or more exacerbations in the past year requiring antibiotics, oral steroids, or hospitalization, for whom we suggest ICS as an additive therapy. Our next recommendation from the ATS is a conditional recommendation with a low certainty of evidence, and here the ATS suggests that in patients with COPD and a history of severe and frequent exacerbations despite optimal therapy, the ATS advises against the use of maintenance oral corticosteroid therapy. And for our last recommendation from the ATS on the pharmacological management of COPD, this was given a conditional recommendation with a very low certainty of evidence, and here the ATS suggests that for individuals with COPD who experience advanced refractory dyspnea despite otherwise optimal therapy, the ATS suggests that opioid-based therapy be considered for dyspnea management within a personalized shared decision-making approach. And that wraps up the ATS's 2020 Pharmacological Management of COPD recommendations. Now, if you're looking for more information about these recommendations or this guideline, you can find the link to the full text available on our website, as well as a free pocket guide at guidelineCentral.com. While you're there, make sure to check out our library of hundreds of clinical practice guidelines and quick reference content from over 45 different medical societies. And we'll see you guys on the next guideline.